Hello and welcome back everyone. So in this video, I will be comparing the unfractionated heparin against the warfarin, and the topics of the comparison will include the source and the chemistry of these medications, the pharmacokinetics, the mechanism of action, the pharmacological effects, the therapeutic uses, monitoring, and the adverse effects. So starting with the source and the chemistry, so the heparin is a natural sulfated polysaccharide that is present in the mast cells, and it carries a negative charge, and the commercial preparations of the heparin are derived from the bovine lung or the porcine intestinal extracts, and there is also synthetic commercial preparations. Now, in comparison with the warfarin is a synthetic coumarin compound. Now, both of the heparin and the warfarin are classified as anticoagulants, meaning they inhibit coagulation and thrombus formation. Now, for the pharmacokinetics, so regarding the absorption, so the heparin can't be absorbed by the gastrointestinal tract because it gets precipitated by the gastric hydrochloric acid. So the heparin cannot be absorbed by the GIT, meaning that we cannot give it orally, so it has to be given either intravenously or subcutaneously. And those are the available formulas of the unfractionated heparin. Now, if we compare it to the warfarin can be absorbed by the GIT, and it is well absorbed with 100% bioavailability. And that is why it can be given orally, but also the oral formula of the warfarin is the only available formula. Now for the distribution, so for the heparin cannot cross the blood-brain barrier or the placenta, so it cannot cross these barriers, while the warfarin can cross these barriers, the blood-brain barrier and the placenta. And that means that the warfarin can get into the brain and lead to intracranial bleeding, and it also can go into the fetus and it may cause bleeding in the fetus. Now let's move on to talk about the mechanism of action. And before we compare the mechanism of action of these medications, first we have to understand some vital points about the coagulation cascade. So on this picture here, we have the coagulation cascade, and the coagulation cascade is mediated by around 12 coagulation factors. And the coagulation cascade starts on this side. So this is here is the initiation of the coagulation cascade, and the coagulation cascade ends on this side with the formation of the fibrin, and the fibrin is the clot, meaning the coagulation cascade ends here with the clot formation. And in the coagulation cascade, we have the intrinsic pathway, which is the pathway here, and we also have the extrinsic pathway, which is this pathway here. And we also have the common pathway, which is represented by these here. So on the intrinsic pathway, we have factors like 12, 11, and 9. And on the extrinsic pathway, we have factors like 3 and 7. And on the common pathway, we have factors like 10 and 2. Now, the external pathway is activated when there is external damage to the tissue, leading to release of the tissue factor, which is factor 3. And when the tissue factor is released, the factor 7 is activated, and the factor 7 activated would activate factor 10, and factor 10 would activate factor 2, and factor 2 would activate factor 1, leading to thrombus formation. The intrinsic pathway, on the other hand, is activated when there is damage to the vessel endothelium and there is exposed collagen. As of that damage, this will lead to the activation of factor 12, and factor 12 would activate factor 11, factor 11 would activate factor 9, factor 9 would activate factor 10, and factor 10 activate factor 2, which activate factor 1, leading to the clot formation. Now, inhibition of any of these factors is what we call anticoagulation. So we can inhibit any of these factors to anticoagulate, but it is best to inhibit factor 10 or factor 2 because those factors are involved in the common pathway, meaning that both of the extrinsic and intrinsic pathway would lead to them, meaning if we inhibit them, we would inhibit both of the intrinsic and the extrinsic pathway. And it is very important to know that we cannot inhibit the fibrinogen, which is the factor 1 here. We cannot inhibit that because this would lead to severe bleeding. So we can only inhibit the other factors, and it is better to inhibit the factor 10 or factor 2. Now, the unfractionated heparin, which is also called the heparin, works by activating the antithrombin 3. And the antithrombin 3 is a natural clotting inhibitor available in the plasma. So when the antithrombin 3 is activated, it works to inhibit several clotting factors, especially factor 10 and factor 2. So the heparin here works to inhibit factor 10 here and factor 2. Now, in comparison with the warfarin inhibits the vitamin K epoxide reductase enzyme in the liver, leading to inhibition of the formation of the active form of vitamin K. So when the warfarin inhibits the formation of the active form of the vitamin K, this will lead to inhibition of the synthesis of the vitamin K dependent clotting factors. And the vitamin K dependent clotting factors include factor 10, factor 9, factor 7, and factor 2. They are collected in the numbers 1972 to make it easier to remember. So on this picture here, the warfarin works to inhibit factor 2, factor 10, factor 9, and factor 7. And the action of warfarin can be antagonized by giving the patient vitamin K. Now let's talk about the onset and duration of the clinical effects. So for the heparin has a rapid onset of action if given intravenously, and the onset is in 1 to 2 hours if the heparin is given subcutaneously. And the heparin has a short duration of action of 2 to 4 hours. In comparison with the warfarin has a delayed onset of action, which is from 24 to 72 hours after administration, and this is the time needed for the depletion of vitamin K and vitamin K dependent clotting factors. And the warfarin has a longer duration of action from 2 to 5 days until the liver produces the depleted vitamin K and the coagulation factors back. Now let's talk about the pharmacological effects. So for the heparin pharmacological effects is anticoagulation in vivo and in vitro, meaning the heparin will work inside the human body and inside the blood collection tubes. In comparison with the warfarin pharmacological effects is anticoagulation in vivo only, so inside the human body only, because the warfarin needs the liver for its effect to occur. So in the blood collecting tubes, it does not work, while the heparin work on activating the antithrombin 3, which inhibit the factors 2 and 10, which only work inside the blood collection tubes. And the heparin pharmacological effects also include the stimulation of the lipoprotein lipase, which lead to decrease the serum triglycerides. Now let's talk about the therapeutic uses. So both of the heparin and the warfarin work to prevent and treat thrombotic events. The heparin is more suitable for short-term prevention and treatment of thrombotic events because it is given intravenously and subcutaneously, while the warfarin is more suitable for long-term prophylaxis and treatment against the thrombotic events because it is given orally. Now, when we say treatment of thrombotic events, we mean that prevent the thrombus propagation in established thrombosis. Because remember, the warfarin and the heparin does not work on factor 1, and this means that they would not dissolve the established thrombus. They only stop the further thrombosis. So we give these medications in thrombotic events to prevent further propagation of the thrombus. And the heparin is indicated for deep vein thrombosis, pulmonary embolism, atrial fibrillation, acute coronary syndromes. It can also be used to prevent coagulation during cardiac surgery, percutaneous intervention, extracorporeal circulation, and dialysis. And the dosing for the heparin is variable, but it is common to start with a bolus dose of 80 units per kilogram intravenously, and then maintained by 18 units per kilogram per hour, and the dosing in the acute coronary syndrome and strokes is much lower because there is higher risk of bleeding. Now, if we compare it to the warfarin is indicated for deep vein thrombosis, pulmonary embolism, atrial fibrillation, cardiac valve replacement, and it's also indicated for reduction in risk of death in recurrent myocardial infarctions, thromboembolic events such as strokes, systemic embolization after myocardial infarction, and the warfarin is given orally and the dose is around 2 to 10 milligrams per day. Now moving on to talk about the monitoring of therapeutic effects of these medications. So for the heparin is monitored by the activated partial thromboplastin time, the APTT, while the warfarin is monitored by the prothrombin time, the PT, or the international normalized ratio, which is the INR. So for the heparin is monitored by the activated partial thromboplastin time, which is checked at baseline and then every 6 hours until 2 or more therapeutic values are obtained. Then it is checked every 24 hours. And the dose titration is according to the value of the activated partial thromboplastin time, and monitoring for adverse effects of the heparin is by the hemoglobin, the hematocrit for monitoring of bleeding, and the platelet are monitored for the adverse effect that we will talk about later, which is the heparin-induced thrombocytopenia, and the vital signs are also monitored. In comparison with the warfarin is monitored by the prothrombin time or the INR. The INR is preferred, and the INR value in patients without anticoagulation is 1, and the INR is monitored serially until the required therapeutic value is reached. And the therapeutic value of the INR depends on the type of the thrombotic event the patient having. Now let's talk about the adverse effects. So for the heparin and the warfarin, they both share the bleeding side effects. So both of them lead to bleeding, and this is usually very dangerous. And it may be a minor bleeding, or it may be a major bleeding like an intracranial hemorrhage, or a gastrointestinal bleeding, or an intraocular bleeding, or a hemoarthrosis. And the bleeding could be treated with immediate stopping of the medication. So first we stop the medication in both of the medications, and then we can use the fresh frozen plasma in both of the medications and that is to replace the clotting factors. And then we can use an antidote, and that is different between the medications. So for the heparin, the antidote is the protamine sulfate, and the protamine carries a positive charge, and in comparison with the heparin carries a negative charge, as we mentioned in the beginning of this lecture. So the positive charge of the protamine binds to the heparin, and this would lead to a stable complex, and 1 milligram of a protamine can bind to 100 units of the heparin. On the other hand, the warfarin antidote is the vitamin K, and usually 10 milligrams of vitamin K slowly given intravenously or intramuscularly to enhance the synthesis of the clotting factors. Now, heparin adverse effects also include that the heparin cannot be given intramuscularly, but if it is given intramuscularly, it will lead to hematoma formation. So it can't be given intramuscularly, it can be given only subcutaneously or intravenously. And a very important side effect of the heparin is the thrombocytopenia. And for the thrombocytopenia, we have two types associated with the heparin. We have the first type, which is non-immunogenic interaction with the platelets, and that occurs within the first 2 to 3 days of the initiation of the heparin therapy, and this is temporary drop in the platelets, and it will recover once the heparin is stopped. Now, the second type of the thrombocytopenia associated with the heparin is much more serious, and it is known as the heparin-induced thrombocytopenia. And this is immune-mediated reaction against the platelets occur 5 days after the heparin. So the second type occur 5 days after the heparin initiation, while the first type occur 2 to 3 days after the heparin initiation. And the second type can lead to thrombosis, so it can lead to pulmonary embolism, deep vein thrombosis, stroke, and myocardial infarction, which is called the heparin-induced thrombocytopenia and thrombosis. So the second type is very dangerous because it may lead to thrombocytopenia and thrombosis at the same time. Other heparin side effects include hyperkalemia, alopecia, and osteoporosis, and this occurs especially with long-term use of this medication. On the other hand, the warfarin side effects include that the warfarin may also lead to gastrointestinal side effects like nausea, vomiting, and abdominal pain because it is taken orally, and it may lead to hemorrhagic skin necrosis, and this occurs when starting the warfarin because in the starting of the warfarin, the biosynthesis of protein C is reduced, leading to temporary procoagulant state. Because remember, the protein C acts as anticoagulant. So if the biosynthesis of the protein C is reduced, this means that we are in a procoagulant state, and this can lead to hemorrhagic infarction of the skin, breast, intestine, and fatty tissues. And this is normally avoided by concurrent heparin administration. So for the first few days of the warfarin use, it is combined with the heparin to prevent the hemorrhagic skin necrosis. Warfarin also leads to purple toe syndrome. Purple toe syndrome is characterized by cholesterol microembolization that causes purple lesions to develop on the toes and the side of the feet. And remember, since the warfarin can pass the placenta, it leads to teratogenicity, which is in form of abnormal bone formation in early pregnancy, and this is called the fetal warfarin syndrome. And it also may lead to central nervous system hemorrhage in the fetus if given in late pregnancy, and it is very important to know that sudden withdrawal of warfarin may lead to thrombotic catastrophes. So the warfarin cannot be stopped abruptly. Finally, let's talk about the heparin and warfarin contraindications. So both of these medications are contraindicated when the platelet count is less than 100,000 because this may lead to bleeding, and they are contraindicated in active, uncontrollable bleeding except for disseminated intravascular coagulation. And the heparin specifically is contraindicated in case of heparin-induced thrombocytopenia. If the patient has a history of this reaction, the heparin is contraindicated, but the warfarin can be still given. And they are contraindicated if the routine monitoring tests cannot be performed for any reason, and they are contraindicated in case of threatened abortion, eclampsia, or pre-eclampsia. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe.